Good afternoon, everyone. At the outset, I would like to thank Dr. Biswas for inviting me and making me a part of this instructional course. My topic, radiological imaging in uveitis. It's a very vast topic, but I've tried to concise it to make it into a 10-minute presentation. Now, what is my role as a radiologist in uveitis? One is to find a causative agent or the etiology of uveitis when there is a clinical dilemma. I don't know how often we are able to help you in coming to a diagnosis because there is so much of overlap in the imaging findings, so we might just land up confusing you rather than helping you. As a part of systemic workup to find out the systemic disease burden. So what does the imaging include? Imaging the orbit and brain in various inflammatory, infective and neoplastic conditions. As a part of systemic workup, you can do the CT chest, CT abdomen, and the skeletal investigations for HLA-B27 to look for sacroiliitis and ankylosing spondylitis and METs and lymphoma. So how do we go about investigating these conditions? We can start from something as simple as an X-ray chest. Further, we can go ahead and do a CT chest, which can be an HRCT or a contrast CT, an MRI of the brain and orbit, and finally it is the PET CT. So coming to the simplest investigation, that is the X-ray chest, which was widely used at Shankar Nethralaya once upon a time, but slowly there is a shift from X-ray chest and to HRCT. Now, why do we have this shift? Basically, it's a good screening tool. It's easily available at all outpatient, and it's very cheap. But it has got certain limitations because 40% of the lung fields are obscured by tissues in the chest, and therefore a negative chest X-ray does not exclude disease. Mediastinal lymph nodes can be easily missed on a chest PA view. So I'll just show you classical examples. This is both are of different patients' chest PA view, showing you a typical cavity in the left mid zone, and there is another small cavity over here with surrounding consolidation, and this is the miliary pattern. Now, when you see something like this, you don't have to do an HRCT chest because your diagnosis is given on a chest radiograph. But when would you go then? Here is another typical case of sarcoidosis. This is the typical presentation of bilateral hilar lymphadenopathy, and this is how you see the calcification in a hilar node. So when you see something like this in a appropriate clinical setting, you know that you're dealing with sarcoid. So then when would you do an HRCT? It is to characterize an abnormality that you see on a chest radiograph, which is not typical, to look for interstitial lung disease. An HRCT chest is highly sensitive in picking up mediastinal and parenchymal lesions. But the main drawback is the radiation dose, and therefore one should limit its use in young adults and children. So what are the indications for an HRCT chest in uveitis is for infections, especially tuberculosis in our country, which is endemic. Granulomatous inflammatory disease like sarcoid in an immunocompromised patients because they have a whole lot of opportunistic infections, as well as TB heads the list, autoimmune disorders and Masquerade syndromes. So let's go through some of the typical findings of TB in an HRCT. A primary TB, you will see consolidation in any lobe. Lymphadenopathy can be with or without caseation, pleural effusion, and all these primary TB lesions usually will heal with calcification. So when you do a subsequent imaging, you will find a calcified mediastinal node or a calcified parenchymal nodule. So this is how a typical caseation looks like. You have a, So this is how a typical caseation looks like. You have a central low signal area, and then there is a peripheral enhancement. This is a typical matted appearance. You can see 2-3 lymph nodes which have coalesced together. So when you have necrotic mediastinal lymph nodes like this, your diagnosis is almost certain. In secondary TB, you get consolidation, which usually involves the apical segment of the upper lobe or the superior segment of the lower lobe, and the second finding you can see is a cavitation. So here is a typical lobar consolidation, which is in the superior segment of the lower lobe. This is the typical apical involvement, the cavitatory lesion in the right upper lobe. There is another entity called as a tree in bud appearance to indicate an endobronchial spread of TB. At one time, this was a typical finding in endobronchial TB, but now this particular finding has been described in a whole lot of infective conditions and metastasis as well. So this is the centrilobular nodules with the branching pattern, which is described in endobronchial TB. Now, miliary TB, I have shown you the X-ray, which shows you multiple miliary nodules, and this is the cross-sectional imaging of the same patient, which will show you 1 to 2 millimeter nodules, which are randomly distributed throughout the lung. So then what are the indicators of active infection? Quite often we see so many focus while doing an HRCT, so you want to know whether it is active or not. So finding of consolidation with or without cavitation, a tree in bud appearance, miliary TB, lymph nodes with central necrosis and pleural effusion are indicators of active infection. So quite often when I get a request from the UVI department, they always ask me whether it is TB or sarcoid. Unless the finding is very typical, it is very difficult for a radiologist to pinpoint and say, yes, this is TB or this is sarcoid, because there is a considerable overlap. So finishing the typical findings of TB, I'll come to the typical findings of sarcoid, which are seen in 60 to 70% of the patients: bilateral hilar lymphadenopathy, parenchymal lesions, which are usually nodules in typical location, which we describe as perilymphatic, subpleural, peribronchovascular. The zones are usually upper and the mid zones, and in the end stage you get fibrosis. Always look for some nodules which are near the fissure, which will give you the indication that this is sarcoid. So what are the indicators of active inflammation on an HRCT in sarcoid? Is presence of nodules, ground glass opacities and alveolar opacities. Chronic disease, what we mean is fibrosis. You will get honeycomb pattern, septal thickening, volume loss and bronchiectasis. So this is a 44-year-old man who presented with biopsy-proven sarcoid, but this was done as a part of a systemic workup, and this is the typical peripheral calcification that you see in the extensive mediastinal nodes. This is the lung window. This is the chest window, what we call the mediastinal window, and this is the lung window, where you can see there are nodules, there is fibrosis. So this becomes the stage 4 fibrotic stage of sarcoidosis. This is just the zoomed view of the same patient, showing you the nodules which are closer to the fissure. There is some amount of consolidation, and all this that you see is fibrosis along with the calcified mediastinal node. So what I described, the nodules which are closer to the fissure. So this is the fissure, and you find the nodules that are close to the fissure and peribronchial thickening. So this was a 35-year-old female with intermediate uveitis. The chest CT just showed non-specific nodules. With these nodules, we cannot come to a diagnosis that it is sarcoid. But the presence of these calcified nodes in the axilla, clinched, and in the abdomen helped us to arrive at a diagnosis of sarcoidosis. Masquerade syndrome, the commonest being lymphoma versus metastasis. So this was a very interesting case, a 36-year-old female who presented with a right eye pain, headache. She had classical signs of ocular inflammation. We did the MRI with contrast, and here you see is an intraocular lesion which is centrally necrotic, showing peripheral enhancement, and there was some reaction in the around the globe. Her HRCT chest showed a cavitatory lesion which looked like a fungal ball. She was biopsied from the lung, and which was inconclusive. 2 months later, she came back with worsening of the right eye. The right eye had almost gone, had melted away, and the biopsy from the eye then revealed a squamous cell carcinoma from lung, and the eye was actually metastasis. Coming to CNS manifestations in uveitis, you have to do an MRI with contrast. Okay, it should not be a plain MRI. Advanced imaging like diffusion, weighted imaging, and MR spectroscopy can help you arrive at a diagnosis, because there are considerable overlapping features. So I'll just run through a few cases. So this was a 17-year-old female who came with an intraocular lesion. You can see the lesion here is dark on T2 weighted image, and the brain imaging showed a well-defined rounded lesion. So this was a choroidal granuloma and an intracranial tuberculoma. Now, when you see something like this, a pachymeningitis, you cannot definitely say that this is TB or sarcoid, because both have the same findings on MRI. Multiple sclerosis, you should look for typically these periventricular lesions. Lymphoma is one which is, can be very confusing because the intraocular lesion is most often not seen on an MRI, and MRI of the brain has to be with contrast because there may be some small lesions which can be missed if you do a non-contrast study. So you have a small intraocular lesion here, but this is a contrast enhancing intracranial lesion. So then what is the role of PET-CT? Is basically in sarcoid for evaluation of the disease extent as a marker of disease activity and to monitor response to therapy. In Masquerade syndrome, to identify the primary lesion and to look for systemic spread. So to conclude, the causes of uveitis is very vast. Imaging plays a very crucial role in identifying CNS and systemic disease. There is a considerable overlap in imaging findings of granulomatous lesions, which poses a diagnostic challenge, and therefore imaging should always be correlated with clinical and laboratory data. So I thank you, Dr. JB, and the team of Shankar Nethralaya UVR department for all the cases that I have shown here. Thank you, sir.